is not a simple linear mathematics now, but rather we are beginning to see a rise in the numbers. Hence, we face a challenging but not hopeless situation, for as long as our approach to defeating the virus is being steadfast on the measures that have been imposed and maintaining solidarity in this approach. We have no choice but to work together, share resources, and deploy the proven strategies that we have learned along the way, which is the only way out. We have learned a lot about COVID-19 since our first case, and today I want to focus on a few lessons that I believe are important in dealing with this pandemic. The first one, of course, is the key weapon of fighting this virus, and that is the measures, containment measures that have been put in place, the hand washing, the personal hygiene, the wearing of masks, social distancing, avoiding public gathering. These are the measures that we have continued to preach and will continue to preach. They have worked in other places, and adhering to them, we can ensure we can suppress this curve of ours, flatten it, as they call it. And this is because the virus is carried mainly by human beings, which is why also staying at home directives have been put in place for those who can in order to limit human movement. And these approaches have been applied in many of the countries that have been ravaged by the pandemic, and they have worked in those countries in suppressing the spread of the virus. So that is the first lesson, is we really need to keep the course. We need to be steadfast in observing these measures, inconvenient as they may seem, and they will require us to make sacrifices in order to be able to observe them, but they do work, and they will be able to keep the spread of the virus down. However, when we stay at home, we have seen where, for instance, stay-at-home restrictions that were placed in some countries and some of the measures that we have mentioned have been lifted. There was an upsurge in the number of infections. I think most of you are familiar with what has happened in a number of countries that had managed to suppress the virus. But on easing some of these measures, there was a resurgence or spikes in the infections. That is why, as a country, we have been very cautious in our approach towards easing of the measures. And I think all of you heard His Excellency the President when he spoke on Saturday, and he gave the reasons as to why some of these measures' time may not yet be there with us. The second lesson is about stigma. Stigma towards those who have tested positive should not be tolerated. Stigmatizing anyone during a pandemic poses a threat to everyone. Experience in dealing with HIV, Ebola, and many other infectious diseases shows that stigma undermines efforts at testing and treating the disease. In fact, stigma drives this disease underground, and that's not the kind of thing that we desire, because we must know where this disease is in order to control and contain it. Stigma divides and turns us against each other. Yet pandemics, and this one in particular, have reminded us again how connected we all are. Our shared vulnerability to the virus should be a source of and solidarity. We must remember at all times that it is the virus which is the enemy, not the person with COVID-19 or those affected by COVID-19. We must therefore care for each other, hold each other's hand, walk together in this fight, and remember that none of us is free of corona until all of us are free of corona. Fellow Kenyans, let me now get to the statistics of the day. Today we have recorded 127 positives from a test pool of 2,247 samples. This now brings the total of confirmed positive cases to 2,989 from 100,683 samples tested so far. And the cumulative number of recoveries to 873. We would have wished to be discharging more patients than admitting. This, however, is not the case for today, because we have discharged 24 people who have recovered from the disease over the last 24 hours. And as I said earlier, this brings the total number of discharges to 873. Today's cases are 124 of these cases are Kenyans and 3 are foreigners who live amongst us, with 84 being males and 33 females. The youngest is a 3-week-old infant, and the oldest is 72 years of age. The distribution of cases in the counties is as follows. Nairobi has 62, Mombasa 34, Busia 14, Machakos 4, Bungoma 3, Kwale and Uasin Gishu 1 each. If we go down to the sub-counties in these areas, Nairobi, the cases are from Kibra 21, Westlands 14, Ruaraka 12, Kamkunji 5, Langata 4, Dagoretti North 3, Makadara, Embakasi South, and Embakasi West 1 case each. In Mombasa, the cases are from Mvita 8, Nyali 7, Changamwe 6, Jomvu 6, Kisauni 4, and Likoni 3 cases. In Busia, all the 14 cases are truck drivers at the Malaba port of entry. In Kiambu, the cases are from Thika 2, Ruru and Kikuyu 1 each. In Kilifi, the 4 cases are from Kilifi North 2, Kilifi South, and Kaloleni 1 case each. In Machakos, all the 4 cases are from Athi River. In Bungoma, all the 3 cases are of truck drivers from Kandui, while the 1 case in Kwale is from Matuga, and the case in Uasin Gishu is from Keses. Sadly, we have lost another 3 more patients to the disease, bringing the tally of fatalities to 88. I send my heartfelt, deepest condolences to the family of the departed. Yesterday, I informed you about healthcare workers and the risk they stand being in front line of contracting various infections, including COVID-19, as they discharge their duties. As pertains to this current COVID-19 pandemic, 72 frontline healthcare workers have contracted the virus from different environments. Out of these, 19 are currently being managed in different health facilities. The risk of infection has, however, not undermined their commitment to duty. I therefore want to take this opportunity to thank them for their dedication and devotion to serve Kenyans even in the face of being infected. In conclusion, I want to remind ourselves of our resilience as a people. This situation has made us overcome several adversities in the past, and I am confident that together, as we stay the course, we shall overcome. Thank you.
Thank you so much. My name is David Muthoka from TV47. I have two questions. The first one being about isolation centers, our national isolation centers. What are the statistics there? Bearing in mind that as of last week Thursday, we noticed that at KUH we had just 3 vacant beds for people who've contracted coronavirus. Which has a 10-bed capacity for some of the people who get infected. We saw that as at Saturday, we had just 1 vacant bed for somebody who could contract coronavirus. And the second question is about Isili, where we've seen a relaxation of some of the containment measures. There are fears of a resurgence, bearing in mind also various capitals within the world did that, and then there was a resurgence. What are the measures to avert potential resurgence within Isili?
My name is Chemutai Goin from Citizen TV. I have 2 quick questions. WHO has stated that asymptomatic patients, it's very rare for them to transmit the virus. Coming to our local scenario here, most of the patients that have recorded positive cases have, as per Dr. Amoth had mentioned, are asymptomatic. Basically, are there measures you're putting in place to ensure that even some of those people who are being discharged out there and have possibly tested positive but are not showing symptoms do not transmit, especially as you begin to enforce the home-based care protocol? Those ones with one single house, are there measures you're trying to ensure that if somebody reports that they do not have a place they can go to, you can put them in a facility until they are able to be managed? And the second one is, the same WHO has also mentioned that elderly and the most vulnerable should use the N95 masks. And even here in the country, we know that even the healthcare workers themselves have been struggling to get it, and those masks are actually quite costly. Possibly, what are you advising for our local scenario here, the elderly patients, the most vulnerable? What should they use as protective gear?
Thank you so much. For the truck drivers, and especially the measurements at the borders, we're still registering confirmed cases in Busia and Bungoma. This was not meant to be the case because you initiated a program whereby testing is going to be done at the point of origin. But now we have cases at the border points. Is it failing? And so what is the alternative? Number 2 for me is Kibra, as it stands right now. I think if it has not matched the cases that were reported in Isli, I think it has surpassed. Is there plans to restrict Kibra in terms of containing COVID-19? Thank you.
Thank you. I will begin with responding to Seth's question on truck drivers. Indeed, you are right that yes, we are registering a number of positives among truck drivers, whether along the northern corridor or even along the borders with Tanzania. And of course, when you truck drivers, it is several considerations come into play, because truck drivers are also part of They are involved in the trade that exists between the states and the flow of cargo across borders. Seth, you yourself know how much time we have spent in trying to engage neighbors so that we could come to a uniform and agreed upon protocol on how we manage these truck drivers and how we ensure that while they will be COVID-free as they cross borders, that at the same time the movement of traffic and cargo is not unnecessarily hindered. And this is why Kenya, in fact, said that we are the first country, I think, in the region that said we will require our truck drivers to actually be tested before they depart on their journeys across borders. 48 hours before they depart, that they need to be tested. As they move on to their journey, they have a COVID-19 free certificate, which is acknowledged across the border, and they are able to move in. And I think that is generally still the point of agreement. But it's going to take a little bit of a while, I think, to streamline this process, because we still have truckers who embark on their journey without a COVID-19 certificate and then end up at the border point where then they have to be held up and wait for testing either on our side or in certain cases even on the Ugandan side. So these are challenges that we are trying to work through to see how we can streamline that. Clearly, if the 48-hour prior testing works for us, then we should not have a problem. But it may take a while for that to work. However, we do anticipate that even with that in place, there is still a need, at least for us as a country, to have testing facilities along those border points, so that in the event that we begin to see people coming in without the certificate or a pile-up of trucks, we need to be able to offer the services at those points within the shortest turnaround times so that the cargo can move. And that is why we have placed mobile labs, for example, in Namanga. We have placed a mobile lab at Mai Mahiu in Busia. We have activated our labs in Busia, at Alupe, at Busia, and we continually are looking to see how we can increase on that capacity to be able to test on the spot and cut down on the time that it would take for truckers to move in between. We are also talking with truck owners and associations of truckers to see how working together, we can be able to improve that situation. Your second question was on Kibra. With the increasing number of positives in Kibra, what is being considered? The increasing numbers, of course, continue to concern us. Kibra is one of those informal settlements that we have been very concerned about. And there are a number of informal settlements in our urban areas. We are all very aware of the conditions in those informal settlements. We are also aware of the livelihoods of people who live in those settlements. These are basically people who live from day to day, having the need to be able to go out and work and bring back something that the family can eat that day. So the circumstances surrounding informal settlements and the considerations that will need to be looked at and are being looked at are slightly different from some of the other areas that we have talked about before, where we have been able to put some measures. It's a slightly different area, and it needs a different look before we can be able to come up with a plan on what we need to do there. But clearly, it's something that is under discussion. It is something that we are looking at very carefully to see how we can approach containment of the spread of the virus in situations like that. Because today it may be Kibra, tomorrow it may be Madare or somewhere else. And we know that those scenarios are likely to unfold as we move forward. Okay, let me go to the question by Rachel of Citizen. No, it was David Mutoka of TV47. You wanted to know about the status of our isolation centers and what bed capacity we have. I think I will pass that over to Dr. Kuria, who might have the numbers and statistics adhered to or not. If those measures are not adhered to, we expect, yes, that there will be an increase in number of infections and so on. We will place measures to contain that, just as we had done it before. So we will be able to, watch out, clearly monitor what is happening in some of these places. And if we feel that there is a trigger point there that things may not be very good, then I think the appropriate measures will be put in place. Chemchai Goin, yours was on two questions. One was on WHO and the statement now that asymptomatic patients may not be high risk in terms of transmission of the virus. And how do we then respond to this new information? What I can say is that, with COVID-19, there are very many unknowns, and there is still a steep learning curve on how this virus behaves, how it behaves in different settings, and what that means for us. This information that has now come out from WHO, I'm sure is an observation from many different places, perhaps, but the evidence is still to be gathered. Sufficient evidence is still to be gathered to be very clear about what an asymptomatic status means. What does it mean? We know we can pick a virus in an asymptomatic. We don't know what the time frame of shedding and the loads of shedding are. Some of these information might be pointing to a fact that it may not be as serious shedding as in other cases that are clinically manifested. But as evidence is gathered, and we feel that that evidence is strong enough, scientific evidence is strong enough for us, then our measures and policies will also be shaped by that information as it develops. Clearly, if we are having a large number of asymptomatics here, then it would make sense that we need to change tact. If the evidence is in place, we need to change tact in the way we deal with that. So asymptomatic, if they turn out to be of low risk, then we can be able to remove them from where we are now keeping them, which is in health facilities, and think of alternatives that will then free up those facilities for those who need those clinical management facilities. Your second question was with respect to the wearing of masks by the elderly, those above 60, and also those who may have underlying conditions. I did talk about these yesterday, and I just want to make some clarifications on that. As you know, the N95 mask is the most efficient one in terms of filtering particles, 95% of the particles. And it is also reserved for specific situations because of its efficiency as a barrier for many particles, viruses included, the small ones too, and also because of its cost and also its use. The N95 mask, because it is so efficient, is also not easy. Anyone who has worn a N95 mask will tell you it is very difficult to breathe in an N95 mask. Therefore, it is really reserved for situations where there is a risk of breathing in the virus from the environment you are, and this applies to healthcare workers who are dealing directly with COVID-19 patients, either in a clinical setting or in settings where they are very close, either sampling them or handling them in one manner or the other. And that really is where it should be best used, so that it prevents that healthy healthcare worker from contracting a virus from the patient. Yes, you could say it could also be used by that patient shedding, but really if one person who is the healthcare has it, I think that is good enough. The one who is shedding may have a great difficulty actually using that mask. In terms of the elderly, we have said the best advice to the elderly is stay at home. Stay at home. That's the safest place to be. Stay at home. If you do have to go out, then wear these surgical, or they also called medical masks, 3-ply, just like other people as you go out for a short walk or a short trip outside. These are good enough to be able to protect you. However, it's also a matter of choice. There may be those who feel concerned that they may really want to protect them, and that is a matter of choice really, and it's upon the person if they want to use an N95. There will be some inconveniences in use of an N95, as I have mentioned, because it's not a mask you can keep on for a long time. It also restricts the level of breathing that you can get. So according to what now the WHO has put out, and it is a measure that the country put in place even before the World Health Organization now accepted that wearing masks could possibly be one of the ways of safeguarding yourself. We have put that measure in place. When in public places, wear a mask. Wear a mask, preferably this surgical mask, but the woven fabric mask is also good enough. Wear it properly to protect yourself. Okay? I think I have answered those questions. So I will now hand over to Dr. Kuria, and maybe he can respond to the numbers on the question on isolation facilities and the capacity that we have in these isolation facilities.
Thank you, Pastor Rashid. I believe the concern with isolation facilities is related to the directive from the head of state, His Excellency the President, Uhuru Kenyatta, on the need for county governments to scale up their isolation bed capacity by 300 beds each. Let me say here that since the beginning of the response to COVID-19, the National Task Force has given guidance to counties to identify and equip quarantine and isolation facilities in each county. And there has been a team that has been going out to assess and ascertain the status of these isolation and quarantine facilities in terms of standard was based on the requirements as provided for isolation and quarantine facilities. And it did confirm that the number of them, of course, may not have met the standards, and they have revised this. And we can confidently confirm here that, so to date, we have more than 101 quarantine facilities across the country, and at least 50 isolation facilities across the country, with a total bed capacity of up to over 3,700 beds. This is what guided the directive given on Saturday, that we need to scale up this isolation bed capacity, considering the modeling data that is now available, that projects that the number of cases requiring hospitalization and ICU care is going to surge in the coming few weeks. And no wonder then that even the restrictions were put in place to try and limit this surge, or at least delay it and prepare and give time for counties to prepare themselves for this surge. So there is adequate capacity, and going by the numbers of patients who are in hospital today, you can obviously say that indeed there is still capacity across the country. But you may have learned that a number of them, Nairobi and Mombasa, may not have been starting to feel the effect of the increasing numbers of these cases. So capacity is still there, but as we go on and start expecting the surge in the coming few months, yes, we need to scale up the existing capacity from where it exists today. Thank you.
Thank you very much. This is Mark Namasa from KTN News. This is a request rather than a question. Will we be able to get the numbers of the people tested per sub-county? Because it might not, if you have overall numbers, it might not give the true impression, because people in the countryside know everyone in Nairobi has COVID-19. Thank you.
My name is Purity Museo from KBC. Two concerns. One, there is a 14-day quarantine that was imposed by the government, especially on the people that are being evacuated from other countries. Just a clarification, are they enjoying the free quarantine services from government facilities, or are they still paying for it? And number two, about 873 people have been discharged from hospitals. How are they faring on? Do we have any of these patients that have been reinfected by corona? Because yesterday there were pictures going around on Facebook that a certain patient who had been discharged from one of the facilities had unfortunately succumbed days later.
Jamhemba from Ebro TV. Bwana Waziri, I would just like to know about, out of the 127 cases, how many are from actually the contact tracing, and then maybe for the Kibra 21 cases, are they as a result of the mass testing? And then Kenyans are just asking all the Kibra people, is the situation out of control for Kibra? Because for the last 3 weeks we have been announcing that, okay, we shall be deliberating on whether to add additional measures for the Kibra people. Is the situation in Kibra out of control?
Okay, thank you. With regards to the numbers tested per sub-county, I think this is information that can be provided. We will be able to break down and be able to share this information once we have broken it down to the numbers that are tested in each of those sub-counties. The 14-day quarantine and those evacuees who choose to go to public health facilities for quarantine, I think the government was very clear. We were clear about that directive that anybody who is quarantined or is isolated for treatment in a public health facility does not have to pay for it. It is the government that will pay for it. However, those who are arriving from outside by air as evacuees or returnees from India and other places, recently we had a flight from India that brought in more people who are people who had sought treatment in India. Those who are coming back after treatment, we provide them that option to be able to return and self-quarantine at their homes, because these are convalescing people and people who are recovering. So we leave them in their households just to complete that period of quarantine. There may be others who are coming back who may feel they do not want to go to a public health facility and may have the means to make a choice. We do have a list of a number of facilities, mainly hotels and others that have are working with us in terms of serving as quarantine facilities. They have a choice to choose where they want to go, but they have to pay for that if they are going to a private facility such as a hotel. The 873 released cases, how are they faring, and what is there any indication that some of these who might have recovered from the virus have been reinfected? As far as I know, and maybe this is new information that we have not yet received, we have not as yet, I think, registered any reinfection of people who have been released. And what we know is that those who have been released are all actually faring pretty well after they have served their period, cleared the virus, and have been released. I think we have not seen any problems with those that we have discharged. The 127 positive cases that we reported today, you would want to know whether, what categories of people do they include? They definitely will include some level of people who are being contacted and traced. They will also include some people who may have been part of a targeted testing somewhere. So this desegregation of the numbers, we can also work on that and be able to tell you how many of these actually were contact tracing, how many of them were people who presented themselves voluntarily for testing, and so on. I think that desegregation is happening. We can share that information once we have it. The issue of Kibra's numbers today, the increasing number, and the numbers particularly today, you wanted to know whether those are part of the mass testing or they are part of just routine contact tracing. The numbers were not too high today, if I recall, for Kibra. I believe that many of these numbers which we are reporting today, we have to remember that we have had a backlog as well. We have talked about that. So some of these may contain some samples from targeted testings that were part of that backlog. But there will also be those that are coming from regular rapid response teams, tracings of contacts, and getting those samples from the contacts. So it will be a mix of the two, if I would say, for Kibra in this case. And then you went on to say that we've been talking about Kibra for a while. What are we going to do about it? Let us wait. I think it's on the table, and a decision will be made at some point on this one. But the fact that that decision has not been made should be some level of comfort that maybe perhaps we're still in control of the situation there. Yeah. I think that covers all the questions that were posed in the second round. Thank you very much.
And would you like a part of us? You can send SMS to your number or your screen. Also, you can call and send a picture what you made. Also, we have YouTube and Facebook. You can go and research GPS Africa. You can watch many other episodes. But don't forget to give us comments. Okay, friends. See you next time. Bye-bye.